was published fairly recently that has garnered some attention. This is looking at patients with cardiac surgery going on cardiopulmonary bypass. And basically, they took the Oxiris filter, put it in line during the bypass for the cardiac surgery. And what in this study they were able to show is that with the EBP, the extra corporeal blood purification, which again in this case was the Oxiris, they were able to show a decreased risk of cardiac surgery associated acute kidney injury in the subsequent 7 days. So again, very interesting, and this is a randomized controlled trial. I think that more needs to be done to validate this, but maybe some more evidence that this could be a promising therapy down the line. The Sera filter is another interesting filter that uses immobilized heparin on the filter to actually remove bacteria. And this company that developed this was able to show actually removal of coronavirus, the COVID-19 virus, during the pandemic as well. So they were also able to get emergency use authorization of this device in the United States. They did a retrospective, again, just to emphasize this is an observational study, but they did a retrospective study and basically showed that in patients that were treated with the Sera filter, they had a significantly lower mortality compared to matched controls, matched by site. But again, this is retrospective and observational study. So to their credit, they are now conducting a prospective gold standard type trial, randomized controlled trial called the Purify RCT, looking at patients with septic shock and randomizing patients to the Sera versus standard supportive care with including dialysis as needed. So I think this study is a very good study, and I think we'll see more emerge from this hopefully in the next year or so. And again, potentially another emerging promising therapy down the line. I'm going to spend the last little bit talking about the selective cytopheric device, which is basically a dialysis cartridge that's placed in line with dialysis. So in other words, after a patient's blood goes through a dialysis filter as usual, it's then run into the outside of the cartridge where we usually run the dialysate. And so it runs on the outside of the dialysis filter instead of inside the semi-permeable membranes, and then it comes back outside, back to the patient. So a very easy to apply circuit compared to our standard dialysis. And what's going on here in this device is this whole circuit undergoes regional citrate anticoagulation to lower the ionized calcium in of the blood that's outside the body, and this has a modifying effect on the leukocytes, both on neutrophils. And so what happens is activated neutrophils encounter the fiber, are degranulate and either removed from circulation, marked for apoptosis, or deactivated and go back into circulation. So the concept here is, again, instead of dealing with mediators, going directly to effector cells like neutrophils and influencing their pro-inflammatory characteristics into non-inflammatory, and similar idea for monocytes as well. So once again, the concept is that normally with severe inflammation, you have activation of neutrophils and monocytes, the development of the cytokine storm, massive either inflammation or potentially immune paralysis from the compensatory anti-inflammatory response. And the idea here is that by using this selective cytopheric device, you can break the cascade here at the level of the activated leukocytes and restore homeostasis and improve overall outcomes. So what have they done so far with this device? Again, starting with just kind of phase 2 type studies looking for safety, and then comparing to historical controls, they have found that in patients that were treated with the SCD, they had significantly lower mortality compared to comparable patients. This is the intention to treat arm, and this is the per protocol arm, so patients that completed all the treatments. And you can see that if they completed all the treatments at a lower overall mortality and significantly lower than comparable, and also a signal towards less dialysis dependency, I should say, more dialysis independence among survivors. Also, by proof of principle, they were able to show decreases in some inflammatory mediators with use of the selective cytopheric device. So once again, these are studies that are not fully controlled studies. They're historical controls. They are proof of principle type studies that are interesting and hopefully promising, but there are ongoing studies that are fully randomized controlled studies to further look at this. They've also done this in pediatrics, and I wanted to include a little bit of pediatrics in my talk. So the SCD has been used in pediatric patients with acute kidney injury plus at least one other organ failure who are getting continuous renal replacement therapy. So once again, it's easy to add this cartridge in line with the CRRT circuit. And what they found was a very good safety signal, so no real issues related to this filter. And what they found was that survival was pretty high and significantly higher than what would have been predicted from kidney prognostic or pediatric kidney prognostic models. And this is a summary of what they found in two of the studies. Again, pretty small studies, just a total of 22 patients. But what they found was a 60-day survival rate of 77% in the patients that were treated in these two studies. And when you compare that to historical controls of very similar patients, the survival was only 55% in those patients. And so based on this, the FDA in the United States, the Food and Drug Administration, actually issued an approval letter for this device as a humanitarian device exemption for pediatric patients with acute kidney injury and sepsis. So really a big step forward in pediatric care. I think that there still needs to be more work that needs to be done, but this is now an approved therapy in the US for pediatrics, and they're pursuing similar things in adults. So just to summarize the SCD part, potentially a promising new therapy. Studies have shown the impact on the inflammatory cascade, and some early clinical studies showing, suggesting improved survival compared to historical controls. But a lot more work needs to go into this, and it's ongoing. So hopefully you'll be hearing more about this in the future as another option, and in particular because it is relatively easy to incorporate into current dialysis protocols. And as I mentioned, it's already been approved in the US and for a pediatric indication. So to summarize the extracorporeal therapy section, again, all of these are actually available right now, at least at somewhere in the world. And yet the experience with these is pretty limited. And I really hope that as a field going forward, with this proliferation of options, we really do more studies with these devices and identify either which devices are going to be beneficial, or probably more realistic, which are the patients that are going to most benefit from these devices. And so just to summarize overall, acute kidney injury and critical care nephrology were very well represented at Kidney Week, as you can see. And really, I only had the time to scratch the surface on the number of things that were discussed there. I think that novel biomarkers have really shown our ability to enhance early identification of AKI, and more importantly, to intervene and potentially make a difference at that time. And I think that a further extension of that may be the development of techniques to subphenotype patients to identify which patients really need therapies and which ones are going to respond to those types of therapies. So I do think that we will see more of that in the next phase and hopefully come into clinical practice. I want to emphasize that AKI prevention is possible. It's been demonstrated in a number of studies now, and I think that we need to have more and more efforts to work on really concentrating efforts to prevent AKI, because I think we all know that how devastating a syndrome AKI is and all the negative outcomes associated with it. And lastly, with the newer extracorporeal blood therapy options, more study needs to be coming, but there's been a lot of excellent research and a lot of promise out there. So with that, I'll stop, and I'll be happy to take any questions.
I'm Dr. Gill from Fortis Hospital, Mohali. Regarding the POISE study, I wonder what was the baseline characteristics of the patients. Because if the patient has severe hypertension, especially uncontrolled hypertension since many years, then hypertension preventing strategy will definitely help and prevent AKI.
Yeah, no, that's an excellent point, and I think that's something we talk about in practice, right? That maybe using absolute thresholds of blood pressure is not correct. We should be looking at, what a patient's relative baseline, what their autoregulation is used to adjusting to. I will say in that study, they did not separate, in the POISE study, they excluded patients with poorly controlled blood pressure. So these were patients that were on were reasonably well controlled on 2 to 3 agents. So they specifically did exclude the very resistant blood pressure patients.
Thank you. And my last question, in CRRT, cytokines are also removed. So in that ways, even CRRT would help in cytokine removal?
Sorry, could you say that again with the CRRT?
CRRT we do with this high flux dialyzers,
yes.
Continuous renal replacement therapy.
Yes.
So even that removes the cytokines from the blood.
Correct. And there were a number of studies early on that looked at high volume hemofiltration just purely for sepsis. There's a study out of France, a multi-center study called the Ivoire study that was published maybe in 2019 now. And basically, those studies were negative, and we don't know exactly why, but a couple of things. Even with high volume hemofiltration, when you think about the things that we're used to removing, their rate of generation is order of magnitudes different than cytokine generation, right?
Thank you.
So I think that just from a practical perspective, hemofiltration is probably not an effective therapy for cytokine removal.
Hello. I'm Dilip Pahadi from Calcutta. My question is the SCD filter you are talking, is it specific to pediatric or it can still be used in adult?
Sorry, could you repeat that?
SCD filter.
The SCD?
Yeah.
Yes.
In adults. What about adults? You are saying the pediatric.
Well, no, I definitely think we need to be, in theory, it could help with any hyperinflammatory syndrome, but I definitely think more studies need to be done. These studies are being done. Examples are the cardiorenal syndrome, patients refractory to diuresis that we would consider dialyzing, hepatorenal, as well as overall sepsis with or without AKI. So I completely agree. There's a lot of hyperinflammatory situations that could potentially benefit from these, but I think we need to be careful and examine these, because obviously they're not all identical. And they're collecting samples to, once again, potentially identify subtypes of patients that may be most beneficial for these therapies as well.
Good evening, myself, Professor Orpita from Kolkata again. So I have 2 questions. My first question is pertaining to the most interested area where you have put your focus, that is the subphenotyping type 1 and type 2 to detect AKI early and address the fluid responsivity. Mm-hmm. So don't you think that to use it in perfect clinical perspective, you need to have a kit-based bedside Ang1, Ang2 kit?
Yes.
So that you can do it instantaneously. Otherwise, the things that we do practice now in ICU, that is the imaging to look at the lung ultrasound and the IVC collapsibility, that would define the need for fluid or dictate the responsivity of fluid more capably.
Yes, absolutely. And you know, there's no point having a test that's a send-out
It
test.
changes, it's
You know,
so dynamic.
2 weeks
AKI
later, we
is
find
so
out if it would have
Yeah,
helped,
yeah.
right? So I didn't mention this, but in that study, what that group has developed, they are working on point-of-care tests. Okay, so in an ideal situation, exactly like you said, it might even be the patient coming into the emergency department. Because when you think about it, that's where the initial resuscitation occurs. So even by the time they come to the ICU, so much has happened to the patient. And you can't change that once it's already happened.
Over
and
24
so,
hours,
yeah,
12 hours.
so you're absolutely right. You know, proof of principle from the study. The next is to evaluate these in prospective studies to demonstrate we can change outcome. But then, before you can translate this to clinical practice, you need this implementation science. You need an accurate point-of-care type device that you can use at the bedside in real time to inform the decision making. Because it's not, this is a thought exercise right now to understand it in retrospect, but to use it in prospectively, absolutely.
And my second question is regarding metformin. I'll be very happy to use metformin across all EGFR. You told that AKI stage 2, 3, you will be using metformin to reduce sepsis. Is it true that you used metformin, the investigators used metformin at any creatinine?
No, so, and sorry, I went over quickly for time limits. They still, I can't remember what cutoff they use, but they're not using it in very low GFRs. So I think they're either using 30, 35, or even 40 at the time. So again, this is a study of sepsis to prevent AKI. It's not in patients who already have AKI.
No. But still, in AKI, it was mentioned
Yep.
that AKI stage 2, 3, they have been put on metformin, and you have looked
yeah.
at, yes.
Yes, that was an observational study. So they were looking merely at patients that were in the hospital that were on metformin. So they were not given metformin for that. They came into the hospital, they were on metformin, they already had it. Then they developed 2, 3 AKI. Presumably they were taken off metformin, but the fact that they were on it before that, their outcomes seemed to be better.
But at that time, at least, they have used across the whole spectrum
Yes.
of creatinine.
Presumably they were delayed in taking off the metformin, yes.
Thank you.
Sure.
Yeah, here, Tarun Shah from Hyderabad. Would you recommend stopping the ACE or ARB before any contrast study with early CKD or not?
I usually don't, to be honest, because obviously the ACE inhibitors and ARB are beneficial on multiple effects, blood pressure effect, of course, cardiovascular. And so if it's a patient with early CKD, EGFR above 30,
For contrast study.
for contrast,
Yeah.
I typically do not tell them to stop anything going into their contrast procedure. I will
Because
say
there was
that,
some recommendation that you stop ARB temporarily before contrast study in
yeah,
ARBs.
I think it depends on your hospital protocol. For us, again, if the EGFR is above 30, we're really not doing anything routine. I'm telling them to make sure they're staying hydrated. For example, if this is a fasting study for an abdominal CT or something like that, that they need, I'm ensuring that they're hydrating. I might hold a diuretic for a day or something like that. But again, for EGFR greater than 30, we also tend to use minimal amounts of contrast these days and low ionic iodinated contrast, low ionic. So the risk is thought to be relatively low. So I think that, yes, we used to be very, very protective of that, but the incidence of AKI in that scenario with EGFR above 30 is quite low, and so is very, very low. So we don't routinely hold those medicines, in part because of the fear that they won't get restarted.
Okay, thank you.
Okay, this will be the last question.
Dr. Abhishek from Kolkata. Sir, my first question is that in patients with AKI who have leaky endothelium, one of the most important contributing factors is obviously low serum albumin, and that is very common in at least our patients, that is Indian population. Sir, in this type of patients, what measures do you usually take to correct the serum albumin?
I mean, it's a very challenging situation, right? Because if it's an underlying issue, it reflects nutrition, which is not going to be very easily fixed, especially in a critical care setting, right? And if it's more of an acute on chronic situation, it's reflecting inflammation, okay, as a negative acute phase reactant. So what you describe is, you're right, is a very common situation, a very challenging one. What we know is that routine use of albumin supplementation is not particularly effective, okay? So it doesn't necessarily help with diuresis, it doesn't help. It can raise the blood pressure temporarily, but it doesn't seem to be associated with better outcomes, and it's typically a transient effect. So even giving large volumes of albumin does not, in a sustained way, elevate the albumin. So that's not a long-term solution either. So it still comes down to basic principles of supportive care, supporting the blood pressure, limiting fluids potentially to avoid third spacing whenever possible, and then treating the underlying condition, getting source control of infection if that's an infection source for sepsis, for example, and then working long-term on nutrition. Nutrition also, use of total parenteral nutrition can help over time, but it's not an acute therapy that has shown to significantly improve outcomes in the short term in that setting that you described.
Thank you, sir. My second question is that what, in your opinion, is the ideal time for starting SGLT2 inhibitors in patients with AKI who are not previously on SGLT2 inhibitors?
Yeah, that's a great question. I wish I had the answer to that. I would say that what I typically do is I try to wait until the kidney function, I believe, has recovered and set into a new baseline. So sometimes that's by the time of hospital discharge, and I think it's always great when patients leave the hospital, when you can give them advice, start them on something, because with the transition from the hospital to a clinic-based, you might have a transition in care as well, and somebody may not be thinking about it. You're just trying to catch up on everything that happened in the hospital. So if you can start a patient before they leave, many times I will follow them up after they leave and start it a month or two later, assuming the kidney function has somewhat stabilized. But that study has not been done to say specifically. I just think the more important thing to know is that you should probably do it in patients that have an indication.
Thank you so much, sir.
Sure.
Okay, with Dr. Pahari, one more.
So the question is actually in heart failure with acute kidney injury, you still use the SGLT2 inhibitor or no?
With patients with
heart failure with acute kidney injury.
With acute kidney injury?
Yeah.
Most of the time we are still holding the SGLT2 inhibitor in the acute setting